Episode 26, A Marathoner Collapses at the Finish Line. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and finish with some practice questions. Today's case is a well-trained marathon runner in his late 30s. He's experienced. He's completed 7 previous marathons with a personal best of 3 hours and 17 minutes. He's attempting to qualify for Boston Marathon, and his qualifying time needs to be at or below 3 hours and 15 minutes. In the week prior to his marathon, he's been fighting a viral illness, describing his symptoms with sore throat and some general malaise. He tapered his training and rested more than usual in the week leading up. He arranged for a friend to pace him for the final half of the marathon, and the race began as a cool fall morning in Minnesota. The race started at 8 a.m. The temperature was 43 degrees Fahrenheit with 99% relative humidity. By the 3-hour mark, the temperature had increased to 49 degrees Fahrenheit and the humidity had dropped to 62%. It was a cloudless day and there was a light breeze. By all standard metrics, this is nearly perfect marathon weather. The runner maintained his qualifying pace through the first half marathon. Around the 20-mile mark, he started feeling hot and began sponging his head at aid stations. With about 5 miles to go, he felt very hot, but doesn't feel like he's in danger. His pacer is actually struggling to keep up with him. Then about 1,200 meters from the finish, he starts hyperventilating. He walks briefly to catch his breath, then resumes running. He crests a hill 800 meters before the finish line, and his heart rate jumps, as measured by his heart rate monitor, from 140 beats per minute to 170 beats per minute. The last thing he remembers is picking up the pace for the downhill finish. His pacer notices he looks pale, and then just 10 meters before the finish line, after almost completing the entire marathon, his legs lock up and he collapses to the ground. Medical volunteers rush to his aid and transport him to the medical tent in a wheelchair. He can't hold up his head properly. He is diaphoretic, confused, tachycardic, and unable to stand. In the medical area, he doesn't respond appropriately to questions. His skin is described as cool, sweaty, and pale. His heart rate varies between 80 and 140 beats per minute. His breathing was initially normal but becomes more labored and drops to 6 breaths per minute. He is drooling and the medical team, is worried about his ability to protect his airway. The medical team is unable to safely obtain a rectal temperature because of excessive, purposeless leg movements. They did check a serum sodium level with a portable analyzer and found his sodium to be 146 millimoles per liter. With his deteriorating respiratory status and the inability to rule out heat illness, they made a decision to transfer him to a local level 1 trauma center. My differential diagnosis: exercise-associated collapse, heat illness, infectious disease complications, exertional rhabdomyolysis, and potential cardiac considerations. This case, I want to recognize, comes from Dr. Roberts. At the time, he was at the University of Minnesota, and I've listened to Dr. Roberts in the past, and he is a physician who has taught me quite a bit about sports medicine. This case was published in Medicine, Science, and Sports and Exercise in 2006. I'm Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026. I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, so he arrives at the emergency department, diaphoretic, and he is not handling his secretions. His Glasgow Coma scale, 6 to 7 out of 15. His vital signs: blood pressure was 124/42, heart rate was 144 and regular, and his respiratory rate was 20. He had bilateral movement of the extremities interpreted as seizure activity that was suppressed with 6 milligrams of lorazepam. The authors felt this may have been phantom running motion that is often seen in hypothermic and hyponatremic encephalopathy. His rectal temperature was obtained and it measured 40.7 degrees Celsius, which is equivalent to 105 degrees Fahrenheit. Based on his temperature, the diagnosis was exertional heat stroke. Cooling began immediately with ice packs, tepid water spray, and fans. Simultaneously, he was sedated and intubated to protect his airway. His temperature dropped to 39 degrees Celsius at 8 minutes, 38 degrees Celsius at 19 minutes, and 37 degrees Celsius, which is essentially normal, at 45 minutes from the initial measurement. While his rectal temperature was over 40 degrees, his skin temperature measured by an external thermometer was measured at a range of 37.7 degrees to 38.8 degrees Celsius. That equates to 99 degrees Fahrenheit up to 102 degrees Fahrenheit. This runner experienced multi-system organ dysfunction. From a cardiac standpoint, his initial echocardiogram showed global hypokinesis of both ventricles with an ejection fraction of just 35%. His troponin peaked at approximately 10, indicating some degree of myocardial injury. His EKG showed sinus tachycardia with an incomplete right bundle branch block. In the first 1 to 2 hours, he produced only 4 to 5 milliliters of bloody urine. Dialysis was a consideration according to the authors, but after cooling and aggressive hydration, 6 liters in the first 3 hours, he began a massive diuresis as his kidneys recovered. His AST peaked at over 1,000 and ALT peaked at over 500. From a coagulation standpoint, his PT and PTT were prolonged and fibrinogen was low. This picture is consistent with coagulopathy related to heat-induced illness. His CPK was measured as 890 on admission, which meets criteria for exertional rhabdomyolysis, but is fairly average for marathon finishers. However, it peaked at 37,000 on day 1. The runner regained consciousness around 8 p.m. on the evening of his collapse. He was still intubated. He was extubated the next morning. He had no memory just before his collapse until he regained his consciousness. All laboratory abnormalities reversed. By day 2, a repeat echocardiogram showed his ejection fraction had recovered to 50% of his normal ventricular function. He was discharged on day 5, but his subsequent recovery was slow. He felt ill for the first 2 months. His muscles ached with any activity for 3 months, particularly his hamstrings with burning and soreness described in his running muscles. At 2 months, a follow-up stress echocardiogram was normal. He resumed light running, and by 6 months he was running regularly, but found it hard to push his training. At 10 months, he completed a strenuous 5-mile race in hot conditions and felt fine. 14 months after nearly dying 10 meters from the finish line, he was considering training for his next marathon. Okay, key learning points. Number 1, exertional heat stroke can occur in cool conditions. The wet bulb globe temperature on the day of his competition was 7 degrees Celsius, well within the low risk category. Yet this experienced, well-trained runner nearly died from heat illness. Metabolic heat production during intense exercise can overwhelm heat dissipation even when environmental conditions seem favorable. Key point number 2, check rectal temperature, especially in athletes who are collapsed. This case illustrated the potential disparities that can exist between the shell and core body temperatures in individuals suspected of heat illness. Third, a preceding illness can be a risk factor for heat illness. This runner had a viral syndrome the week before the race, and obviously infection can impair thermoregulation. Fifth point, and this is what I want to emphasize, rapid cooling saves lives and organs. The amount of time the body spends above 40 degrees Celsius correlates with morbidity and mortality. This runner had approximately 37 degree minutes above 40 degrees Celsius. Fatal cases often exceed 60 degree minutes. His relatively rapid cooling, reaching normal temperature within 45 ED arrival, likely explained his complete organ recovery. So importantly, on-site cooling before transportation is the preferred method for reducing temperature, and ice water immersion achieve cooling rates of around 8 degrees centigrade per hour. So in summary, exertional heat illness is a life-threatening medical emergency characterized by core body temperature exceeding 40 degrees Celsius or 104 degrees Fahrenheit, and central nervous system dysfunction occurring in the context of strenuous physical activity. Unlike classic heat stroke, exertional heat stroke can occur in young, healthy individuals and even in temperate climates when metabolic heat production from exercise exceeds the body's ability to dissipate heat. Survival is directly related to the speed of temperature reduction. Here is the principle of cool first, transport second. Cold water or ice water immersion is the gold standard treatment with faster cooling rates than any other method. Importantly, water temperature matters less than the act of immersion itself. Cooling should be initiated as soon as possible before transportation, and with a prompt diagnosis and effective cooling, exertional heat stroke has achieved 100% survival in some series. In terms of returning to activity after exertional heat stroke, patients should refrain from physical activity for at least 7 days after release from medical care and then gradually resume activity over 2 to 4 weeks. Some individuals may require heat tolerance testing if prolonged sequelae develop. Okay, practice questions. Number 1, a 22-year-old male football player collapses during preseason practice on a hot, humid August afternoon. He is confused, diaphoretic, and combative when approached. His rectal temperature is 41 degrees Celsius. Which of the following is the most appropriate initial management? A. Administer acetaminophen 1,000 milligrams rectally and transport to the emergency department. B. Apply ice packs to the neck, axilla, and groin while awaiting ambulance transportation. C. Initiate cold water immersion on site before transportation. D. Administer dantrolene by IV and begin evaporative cooling. E. Start IV normal saline and transport immediately to the nearest emergency department. The correct answer is C. This patient meets diagnostic criteria for exertional heat stroke with a core temperature greater than 40 degrees Celsius with central nervous system dysfunction. The cornerstone of treatment is rapid cooling, and cold water immersion is the gold standard. The principle of cool first and transport second is critical, and cooling should be initiated first before transportation. Antipyretic agents like acetaminophen can be ineffective in heat stroke and may worsen coagulopathy and hepatic injury. Ice packs alone can achieve cooling rates approximately half that of cold water immersion, but immersion remains the best option. Dantrolene has not been shown to improve outcomes in heat stroke. While IV fluids are appropriate, immediate transport without on-site cooling delays definitive treatment and worsens outcomes. Okay, question 2. Which of the following clinical features best differentiates exertional heat stroke from heat exhaustion? A. Core body temperature greater than 38 degrees Celsius. B. Presence of profuse sweating. C. Altered mental status. D. Tachycardia and tachypnea. E. Nausea and vomiting. The correct answer is C. A change in mental status, which can include confusion, delirium, agitation, combativeness, and or seizures, is the hallmark feature that differentiates heat stroke from heat exhaustion and other milder forms of heat-related illness. Heat exhaustion may present with mild temperature elevation, fatigue, weakness, nausea, and headache, but without altered mental status. Sweating is typically present in exertional heat stroke, unlike classic heat stroke where the skin is often dry. Tachycardia and nausea and vomiting occur in both conditions. The diagnostic threshold for heat stroke is core temperature greater than 40 degrees Celsius combined with central nervous system dysfunction. Okay, question 3. A 28-year-old female marathon runner is being treated for exertional heat stroke with cold water immersion. Her initial rectal temperature was 41.5 degrees Celsius. At what target temperature should active cooling measures be discontinued? A. 40 degrees Celsius. B. 39.5 degrees Celsius. C. 38.5 degrees Celsius. D. 36 degrees Celsius. And E is 35 degrees Celsius. The correct answer is C. The target temperature for cessation of active cooling is 38 to 39 degrees Celsius, ideally reached within 30 minutes of presentation. Common practice targets a temperature of about 38.5 degrees Celsius to minimize the risk of clinical deterioration while avoiding overcooling. Cooling to normothermia of 37 degrees Celsius or below risks hypothermia, as the core temperature may continue to drift downward after active cooling is stopped. Question 4. A high school athletic trainer is developing a heat illness prevention protocol. Which of the following is the most important modifiable risk factor for exertional heat stroke in athletes? A. Sickle cell trait. B. Lack of heat acclimatization. C. Male sex. D. Age greater than 35 years. E. A family history of malignant hyperthermia. The correct answer is B. For athletes, the most common modifiable risk factors for exertional heat illness are low physical fitness, lack of heat acclimatization, obesity, and heat waves or unexpectedly hot weather. Heat acclimatization achieved through gradual exposure to exercise in the heat over 10 to 14 days significantly improves thermoregulatory capacity and is a key preventative strategy. Sickle cell trait is a risk factor, but it's not modifiable. Male sex and age are not among the primary risk factors in athletic populations. And while malignant hypothermia trait has been suggested as a potential predisposing factor, this remains controversial and is not a primary target for prevention protocols. Okay, question 5. A 19-year-old male cross-country runner experienced exertional heat stroke during a race 3 weeks ago. He was treated with cold water immersion and recovered fully within 30 minutes. He was discharged from the emergency department after observation. He now feels well and wants to return to training. According to current guidelines, which of the following is the most appropriate recommendation? A. He may return to full training immediately if asymptomatic. B. He should refrain from exercise for at least 7 days following the episode, then gradually return over 2 to 4 weeks. C. He requires heat tolerance testing before any return to activity. D. He is permanently disqualified from competitive running. E. He may return to training after a normal stress echocardiogram. The correct answer is B. Current guidelines recommend that athletes refrain from physical activity for at least 7 days after release from medical care following exertional heat stroke. Then gradually resume activity over 2 to 4 weeks. Immediate return is inappropriate given the physiologic stress of exertional heat stroke. Heat tolerance testing is typically reserved for athletes with prolonged recovery, recurrent episodes, or persistent symptoms, not routinely required for uncomplicated cases with a rapid recovery. Permanent disqualification is not indicated for a single episode with full recovery. And while cardiac evaluation may be appropriate in some cases, a stress echocardiogram is not the primary determinant of return to play timing. Question 6. During a marathon in 10 degrees Celsius weather with 65% humidity, a 35-year-old male runner collapses 100 meters from the finish line. He is confused and diaphoretic. His rectal temperature is 40.8 degrees Celsius. He reports having a cold with sore throat and fatigue during the week before the race. Which of the following factors most likely contributed to his exertional heat stroke despite the cold environmental conditions? A. A low ambient temperature prevented adequate sweat evaporation. B. His recent viral illness impaired thermoregulatory function. C. Marathon running does not generate sufficient metabolic heat for exertional heat stroke. D. 65% humidity is too low to cause heat retention. And E. Exertional heat stroke cannot occur below 21 degrees Celsius. The correct answer is B. This scenario obviously mirrors the case study that we just explored about exertional heat stroke during a cold weather marathon. Viral illness in the days preceding exercise is a recognized risk factor for exertional heat stroke, as infection can impair thermoregulatory function and prime the inflammatory system. Exertional heat stroke can occur in surprisingly cool conditions when metabolic heat production from intense exercise exceeds dissipation capacity. Low ambient temperature actually facilitates heat dissipation, and marathon running, of course, generates substantial metabolic heat. The humidity level was not prohibitively low, and there is no minimum temperature threshold below which exertional heat stroke cannot occur. Thank you. We'll see you next time.